Welcome to the Buffalo Model Approach to Auditory Processing Disorder, an introduction to diagnosis and treatment. This presentation is provided by the International Guild of Auditory Processing Specialists, or IGAPS, in conjunction with the annual Simple and Effective Workshop. IGAPS thanks audiologist Dr. Sarah Zlomke for the use of her slides. My name is Donna Teretkin, and I will be the narrator for this presentation. To understand APD, we need to think about the entire auditory system, starting from the detection of sound through the peripheral hearing system. This hearing system is developed at 20 weeks gestation and begins to bring sound to the central auditory system. Some may associate auditory processing disorder with the central auditory system alone. However, there should be no argument that the peripheral auditory system directly affects the central auditory system. And, as you will learn, we can assess central hearing disorder in the presence of a peripheral hearing loss using the SSW test. The central auditory system includes the brain and the auditory pathways that bring information to the hearing centers of the brain. In these illustrations, you can see that the majority of the left ear pathways cross to the right side. These sounds must then cross over the corpus callosum to the speech and language center in the left hemisphere. The right ear pathways cross over to the left side right away, resulting in a shorter, more efficient pathway. There are also ipsilateral auditory pathways on each side, although they are less dominant. As one can see, these two pathways must be working cooperatively to create the correct representation of sound within the auditory cortex. By studying patients with known neurological disorders and lesions, we have learned that the peripheral portion of the auditory system serves as a bottleneck for information transfer. Disorders at this level can have a dramatic impact on hearing ability. At more central levels, the effects of the disorder may be more subtle and can be challenging to measure. For example, in the elderly, not only do we see peripheral hearing loss, but we also begin to see neural degeneration in the auditory nerve, brainstem, and cortex. Therefore, we look more towards the presenting symptoms to help identify and define APD. Since APD is complex and may involve multiple neurological systems in addition to the auditory nervous system, APD is associated with a number of behavioral manifestations and a variety of symptoms, some of which may be subtle. In addition, professionals must consider how other cognitive processes may relate to these symptoms. Music difficulties may be a sign of deficits in prosody. Many times, these patients have difficulties perceiving stress, rhythm, and intonational patterns of speech, which can lead to poor pragmatics and poor social communication skills. When receiving referrals for APD, it is common to hear people report that individuals act like they have hearing loss despite normal hearing. In some cases, patients do have hearing loss, but are not progressing as well as other patients with similar hearing losses. Models are a useful way to organize and understand complex concepts. With multidisciplinary patient care, we must consider teachers, speech-language pathologists, psychologists, physicians, and other providers. Having a model system makes it easier to convey the information to all these different professionals. In this presentation, and in the forthcoming Simple and Effective workshop, we will be describing the Buffalo model. There are others, and they share many similarities. The Buffalo model utilizes 4 categories. The categories help to organize test findings, to explain APD more easily to others, and to develop a therapy program and to implement other interventions and/or accommodations. The decoding category of the Buffalo model is related to phonemes. Phonemes are the smallest units of words, and words make up sentences. Therefore, phonemes, or speech sounds, are very important for learning languages. One must be able to process individual sounds and hold them in memory long enough to put them together to form a word. Decoding is related to blending speech sounds to form words and also to segmenting words into individual speech sounds. The area of the brain associated with these skills is referred to as Luria's phonemic zone, located in the middle posterior portion of the superior temporal lobe. Delayed responses occur because people with decoding deficits are not always clear about what they have heard and have to take extra time to figure out what the response is. If they don't have this time, they may appear confused or respond inappropriately. The problem can be even greater for unfamiliar words. Those with decoding deficits may have difficulty with phonics because they cannot remember or manipulate phonemes. Spelling is hard because they must be able to use the sounds to spell. Poor decoders may compensate with a good visual memory. Articulation skills may be affected because poor input means poor output. Poor decoders have difficulty following directions, not because they forget necessarily, but rather they may be confused. The second category in the Buffalo model is tolerance fading memory. This category is related to extracting speech from background noise, noise tolerance, and short-term auditory memory. Individuals with disordered TFM are easily distracted by noise and show inattentiveness. In some cases, they become anxious about the noise. I have a 7-year-old girl right now that can sit still and repeat back words in quiet, but as soon as there is noise, she is bouncing off the wall and wants to leave to go to the bathroom because it is too difficult. I can go back to words in quiet and she sits back down and gets 100%. In school, students often have reading comprehension difficulties as they can read the paragraph, but they cannot remember it. It could be due to poor memory and/or high levels of distractibility. In addition, they have trouble remembering directions and may only do 2 of 3 things in a multi-step direction. The organization category of APD is related to maintaining proper sequence of information. This problem is a labor-intensive problem, requiring a great deal of monitoring information that is heard and seen. It typically occurs when individuals have decoding and tolerance fading memory deficits. For instance, listeners with decoding problems may compensate by taking extra time to respond. However, if they have tolerance fading memory problems, they may not be able to remember the information long enough or remain undistracted by the noise before responding. When they are working so hard to monitor what they hear, they may not have any brain capacity left to sequence the information they heard or to understand the importance of what was said. People with organization deficits are described as messy and disorganized. Their rooms, desks, backpacks, school cubbies, etc. may be cluttered and untidy. In addition, they have difficulties organizing ideas and spelling. Organization has been related to the frontal temporal and frontal temporal parietal regions of the brain by Luria in 1970, Efron in 1963, and Katz and Pack in 1975. The integration category of the Buffalo model is related to the corpus callosum. The integration category is the most complex category of APD. It has to do with bringing information together across modalities and processing centers. If you can recall the early slides that illustrated the ipsilateral and contralateral auditory pathways, integration is related to how what we hear crosses midline via the corpus callosum and is processed in both hemispheres of the brain. If there is an integration problem, these individuals may present with long delays. They typically answer correctly and with seemingly little effort when they finally do. Patients may present with severe reading and spelling problems, dyslexia, difficulties with auditory visual integration, and poor musical and singing skills. Integration deficits are commonly found with neurological dysfunction or previous history of neurological problems. For example, I had a patient with a syndrome that caused the left side of her body, including the left hemisphere of her brain, to be smaller. This can explain why integration deficits are present. The Buffalo model categories are related to specific areas of the brain, as shown in this slide. This information has come from advancements in current imaging techniques and from years of testing done with patients with known brain lesions. Note that this model does not suggest that APD is caused by brain damage, but instead APD could be caused by slower development or different patterns of neural operation. In fact, the SSW test was originally developed as a site of lesion test. Later, Katz had experience with cases where individuals were presenting with similar symptoms as those with known brain lesions, but they did not have any brain lesions. He then used this information and experience to expand the SSW scoring and analysis so that it could be used to identify auditory processing disorders. This is the most common use for the SSW today, as advances in medical imaging serve our site of lesion needs. In fact, the SSW test is the oldest and most widely used diagnostic APD assessment tool for audiologists. You will be hearing more about the categories and associated brain regions during the workshop. Now that you have been introduced to the Buffalo model approach, let's talk about some specifics on the diagnostic process using the central test battery by CATS. Referrals have come from PCPs, ENTs, speech pathologists, audiologists, teachers, parents, psychologists, occupational therapists, reading specialists, and others. Many times, other evaluations have been normal, but difficulties still exist, or current interventions are not working as expected. Case history information is important because it helps us understand what APD deficits may be present. Also, some of these case history findings can be a cause of APD and may warrant a referral for APD testing. We will be talking more about the intake process and case history information during the Simple and Effective workshop. We may have been trained, if we were trained at all, that people with hearing loss cannot have APD by nature of the peripheral loss. The Buffalo model approach subscribes to the idea that if one has peripheral hearing loss, one likely also has APD, as the system is not receiving normal input. The SSW test can be used to assess those with a mild, about a 40 dB HL pure tone average, hearing loss, using some modifications for presentation levels and correction factors based on word recognition scores. If ear advantage findings are present with bilateral symmetrical hearing loss, it could indicate APD. Special test populations may just need extra breaks, more reinforcement, etc. It may take more sessions, but results after therapy as reported by CATS are similar to other typically developing kids with APD. With ADHD, we would typically see a global reduction in scores if it was attributed to attention. If an ear advantage finding is present, we can rule out attention factors. We will be discussing the 3 Buffalo model tests in more detail during the Simple and Effective workshop. We will also be demonstrating test administration and practice scoring and analyzing each test. Now, we would like to introduce you to the Buffalo Model Therapies. The team approach is very important in order to consider all learning problems. Sometimes you will have a child who performs at grade level and is not eligible for special education or educational support services at school, but still may need APD therapy. We can reach our treatment goals by using these approaches. Overall, intervention should focus on remediating the underlying auditory deficits as well as improving the individual's ability to function in real-world communication and learning environments. Compensatory strategies can help one overcome APD by strengthening higher-order skills that can impact auditory functioning. We know a lot about brain plasticity from the ways brains change or reorganize with profound congenital hearing loss by looking at studies with children with otitis media or adults with otosclerosis. We see that both children and adults can recover from strokes, although children typically recover quicker. Many researchers state that plasticity and maturation are based on stimulation. Stimulation and experience activate and reinforce specific neural pathways, and unstimulated pathways fall into disuse and may atrophy. Stimulation must occur ideally within a critical period. However, we should continue to view auditory processing intervention efforts as it is never too late. We see many adults, with and without hearing loss, benefit from intervention. Auditory training activities may include intensity, frequency, and duration discrimination, phoneme discrimination, temporal gap discrimination, temporal ordering, pattern recognition, lateralization and localization, discrimination of speech and noise, short-term auditory memory training, enhancing perception of stress, rhythm, and intonational aspects of speech, and others. Initially, auditory training is intended to remediate the basic issues so that we can then more easily remediate the associated issues. Auditory training should be challenging and motivating without being too difficult and overwhelming. The work should be focused near the individual's skill threshold. Learning is reduced if the training task is too easy or too difficult, as the task demands may either understimulate or exceed the participant's cognitive capacity, and in either case, motivation may be decreased. We are not sure how much practice exactly is needed. Studies have shown different things. Temble et al. Revealed that significant changes in behavioral, perceptual abilities, and neural representation of speech can occur after just 5 days of training. In addition, the results showed that the improvements can generalize to other untrained stimuli. Results have shown that it is possible that the intensity of treatment, repetitive auditory stimulation and engagement, and motivation of the subject are more essential to efficacy and outcomes than is the specific auditory skill trained. The Phonemic Training Program, or PTP, trains 38 phonemes or speech sounds in the Buffalo Model Program. It can be used for children as young as 4 years of age. The Phonemic Synthesis Program is another decoding training module in the Buffalo Model. Words and Noise Training, or WINT, addresses TFM deficits in the Buffalo Model. It is used to help improve speech understanding and noise, and to improve noise tolerance. Short-term auditory memory training also addresses deficits in the TFM category. Although noise and memory are not functionally related, we do know that those with poor scores in noise also have poor scores in memory. Therefore, the Buffalo Model puts noise and memory into one category. Integration training is often done in a second round of therapy after the more basic decoding and tolerance fading memory problems are addressed. CATS developed the Dichotic Offset Training Program for integration therapy. It uses 4 letters of the alphabet in a similar format as the SSW test. The offset times for the competing letters are variable from 500 milliseconds to 0 milliseconds. This program is used in conjunction with a dichotic offset measure program, which is the assessment tool for DOT. There are other programs for integration training as well. The Dichotic Interaural Intensity Difference, DIID, by Music is one, and Acoustic Pioneers Zookeeper Skyscraper is another. And we can employ other non-dichotic listening trainings for integration therapy as well. The goal is to improve right and left brain communication. We will be presenting more unexpected and documented outcomes using the Buffalo Model therapies and other therapies in the Simple and Effective workshop. Spoiler alert, it is good stuff. The Simple and Effective Workshop committee members receive valuable feedback from workshop participants each year. Many are learning about the Buffalo Model approach and the finer details of the SSW test for the very first time at the workshop. This preview presentation was intended to introduce you to some of the terminology and concepts that will be expanded upon throughout the 3 days of learning and hands-on practice. Your workshop instructors and support team will be very happy to help you with any unanswered questions when we see you in May. If you have any immediate questions about registration, travel, or accommodations, please visit www.igaps.org for more information and ways to connect with your workshop hosts directly. IGAPS would like to thank Dr. Sarah Zlomke once again for her permission to use her slides. And thank you to all our volunteer committee members and board members who are dedicated to sharing auditory processing and the great work of Dr. Jack Katz with all of you.